Perfect. So as I said briefly, for those of us who are just joining now, my name is Dr. Sarah Fox, and I'm going to be running our presentation today on clinical intakes. I know, again, Erica already put in the chat that we have the sign-up sheet for attendance, so please make sure you fill that out so that you get credit for that. And really just wanted to start off by giving everybody a big thank you for attending today. I know it's a Monday. I know we're giving up time out of our busy schedules, both clinically and personally, to be here. So I really appreciate that, right? And I think clinical intakes is a really interesting thing for us to be talking about all together today, right? Because it is something that all of us do all the time, right? Like, lots of us on a weekly basis, certainly on a monthly basis, we're doing this. But whether we are a really seasoned clinician that feels very comfortable with clinical intakes, or if we're kind of newer to practice and starting to figure out what our style is, what we feel comfortable with, this is a great place for us all to be meeting and figuring out how we can become as best as we can at this really important first point of contact with our clients, right? This is our first introduction to our clients and us to them. And there's really quite a lot that we're trying to do in this initial session with them, right? So we are trying to build rapport. We're trying to, if we have time, get to a treatment plan. We are thinking about our diagnostic impressions. We're trying to instill some hope in our clients, make them think, hey, I was right for coming to therapy. This can help, this can work. And we're also getting a lot of really good background information about them and what they want to get out of the experience, right? And it can feel kind of daunting to try to do all of these different things, juggle all of these different things all at once. So that's really why we're here today, is to kind of walk through what it could look like to do this successfully and confidently with our clients, and make sure that we're feeling able to put the best foot forward with our clients right from the get-go. So briefly, I'll kind of introduce myself a little bit more, and then also we can kind of talk about the setup for today. So as I said, my name is Dr. Sarah Fox. I'm a clinical psychologist working at our New Directions Mental Health Office in Pittsburgh, PA. I primarily work with adults in a wide range of presenting concerns. I also provide clinical supervision for our master's prepared therapists working towards licensures. Prior to being at New Directions, I have had experience in college counseling, forensic assessment, therapy, as well as inpatient behavioral health. So just to give you a little bit of information about myself. In terms of our presentation today, ideally, we're looking to talk and kind of present for maybe like 45 minutes and then give ourselves, a good 15 minutes if we can at the end for any kind of questions that we may have. That being said, I love engagement. So if we have questions midway through the presentation, please feel free to raise your hand or to throw it in the chat. I know Erica and Jack are kind of monitoring that for us, which I appreciate. So, feel free to kind of shout out those questions to me. As I said, with me sharing the screen, I'm not really able to look at the chat. It just doesn't allow me to do both at once. But, please raise your hand, shout it out, put it in the chat. Somebody will let me know, because as I said, we will definitely make sure we have time at the end of our presentation today for questions, but they're going to come up as we go, and that's completely fine. This can be more of a conversation, and that's kind of a good thing. Okay. All right. So now that we kind of have our general setup for today, we can go ahead and get started by talking about what our training objectives are going to be like for today. Okay, so we want to get an understanding of why the client is coming to therapy and what they want to gain from it. I think this is a really important thing for us to not lose sight of in our intake and across therapy, right? We really want to understand right from the start what they want to get out of therapy, right? I'm sure we've all had that experience where we have a client who comes in and we're like, okay, totally see the problem, totally see what's going on here. let's get after it. But that's actually not maybe what they're seeing as the problem or as the biggest issue at hand, right? And the reality is, I'll talk about this as we go, but therapy is a team sport, so it's kind of us providing our clinical expertise and helping them understand issues they may not be aware of. But at that same time, we always have to keep it focused on what they want to get out of therapy. Things will morph, things will change, but we want to really make sure we're hearing what they're coming in for. So that's going to be a focus today. We're also going to want to understand the client's life situation, right? Like, what kind of history are they coming in with? What's their educational background? What's their support system? All these things that are going to help us have a really strong base of information so that we can provide the best care possible and make a really strong treatment plan with them. And lastly, we're going to be also focusing on identifying our diagnostic impressions, right? As well as some relative strengths and weaknesses that our clients may be coming into therapy with. This is going to be really helpful for our treatment planning, right? Understanding what the diagnosis is, what symptoms are going to be prevalent, that helps us understand what are some evidence-based practices we might want to employ here. What specific goals of the clients can we weave into our clinical work based on the diagnosis. A brief note on clinical intakes and the importance of them. I think I kind of started off today talking about why they're important. But I think looking at some numbers can also be pretty helpful, right? So as we all know, especially in a post-COVID world, there is a really strong need for our services, right? So more than 20% of adults in the United States are struggling with some kind of mental illness, and 4% of adults are living with quite a serious mental illness. So again, there's a really strong need for our services, and really the clinical intake is our client's gateway into therapy. Especially if they've never been to therapy before at all. Not only is it their introduction to us, but it is their introduction to the mental health system in general, right? So we have a lot of opportunity to provide a really good experience right from the get-go. And again, it's also important that we're here for our clients because, as we know, mental health can change over time depending on a lot of different factors, right? Things that may be going on at work, financial stressors, physical health issues, substance use issues. Again, I think COVID's a great example of this. I mean, it totally changed the landscape of what was going on for people mentally, and I think we're still seeing the impact of that. So again, as we all know, this is preaching to the choir, but there is definitely a high need for what we are providing in this really pivotal contact point in therapy. So some of the goals of clinical intake that we're going to be talking about this today, again, as I said, the clinical intake is really just a welcome to therapy for our client. Our goal is to get our clients really comfortable with the idea of being in therapy or continuing it if they've been in it before. Something that I think is really important for us to remember as clinicians is that for us, we do this all the time, right? We talk to people every single day. They tell us their deepest, darkest secrets. It's what makes our job so amazing, right? For people to be so open and vulnerable and honest with us. So for us, this is typical, even when we first meet somebody, right? I mean, yeah, as clinicians, we might get a little bit of those jitters the first time we meet a new client, like, I wonder what's going on with them. I hope that I'm a good fit for them, that kind of stuff. But we've been here before, right? Our clients, that is not the case, right? Even if they've been in therapy for a long time or they've had a few therapists, they really haven't done this very much. They haven't met a new clinician. And if we look at it from their eyes, they are meeting this complete stranger who's nice, but they're meeting this complete stranger and they're kind of expected to tell them what they're struggling with most in the world, right? I mean, gosh, that is super, super hard and vulnerable. And so I think if we can really keep that in the forefront of our minds and come at it with that compassion and that understanding in everything that we do with them, that's already going to put us at a really great start with them. And again, I'll probably reference this again, but I always try to like to kind of acknowledge that and like thank them for being vulnerable in the space. Because again, easy for us, or at least typical for us. For them, lots of bravery is needed just to get through the door. Okay. In therapy, we also want to get across ideas that therapy is a confidential space. We'll get more into informed consent a little bit later on. Therapy is a process of kind of accepting yourself as you are. And therapy is a space that we can create to be safe and allow you to explore how you've been feeling and kind of who you are. In addition to kind of getting those ideas across, I also really like to take some time to set the scene for therapy to them, get them the logistics of therapy, right? So I often will talk about what makes an intake a little bit different than a regular therapy session. I'll let people know that I've looked at their paperwork, that I appreciate them filling all that out. I'll let them know that, yeah, I'm going to be hearing in their own words today what's bringing them in. I'm going to be getting a lot of biographical and background information. A typical session won't quite look like that. Typically in therapy, the client's the one that we want to be doing most of the talking. Letting them know how long therapy is going to be, depending on your clinic, depending on what they're scheduled for. Is it going to be 55 minutes, 45 minutes, whatever it may be? I also let clients know everybody's different. As I'm talking to my clients for intakes, I do type information down just because it's a lot to get, and I'll let them know. Typically, I won't be doing that. I mean, again, this varies based on clinician. I don't take notes during my sessions, but I'll let them know I am going to be typing as I'm talking if that's okay with you, but we won't typically do that, kind of get that consent and okay from them. This can also be a kind of nice time to help them start to understand the collaborative nature of therapy. I think a lot of our clients come to see us and work with us, and they're kind of expecting like a medical model, right? When you go to the doctor and you say, hey, I have this problem, and they say, okay, tell me about your problem. Here are your symptoms. Okay, here's the treatment. This is what you're going to do. Go home and do it, and come back and we'll talk about it. And therapy is really not that, it's not that prescriptive, right? It's a collaborative process where you and the client are working together to come up with your goals, to figure out how you would go about achieving these goals. It's a non-linear process. There's ups and downs. A lot of times people have heard this idea that progress isn't linear, right? And so I think what they think that means is it goes up and it goes down and up and down. And that happens sometimes, certainly. But I like to explain to clients, therapy is, and I get some chuckles when I explain it this way, but therapy is kind of more like a tornado than like an up and down line, right? So we're kind of circling around our problems. Like we're going to keep coming back to some of the same stuff. But the idea is if we can make that circle tighter and tighter and tighter and come to kind of like the core of the issue, that's what it might look like. So really kind of socializing our clients to what therapy is going to be like with you specifically, but also just in general, because again, like I said, I think people expect it's going to be like when you go to the PCP, and it's just really not quite like that.
Hey, Dr. Fox, I think we got a good question in the chat that might be helpful to stop here with. We had a question from Kai, I think, hopefully I'm pronouncing that right. When doing an intake with a minor and somebody who needs another adult with them, how you discuss the process with both parties.
And am I understanding right, Kai, that that's kind of like the informed consent process, maybe?
Yeah, like the informed consent process. But also I was thinking like specifically I have a client who has an inability to like speak for himself, like understand his needs, but is able to engage in like therapeutic activities. But how would you explain that like the client, even without the ability to like speak for himself, is still the main focus without like discrediting like what a caregiver or a parent would be doing for that client?
Yeah, that's a really good question. And when you're saying your client's not able to speak for themselves, like to the extent of they're nonverbal, or they just don't have a lot of good insight, or developmentally they're not able to really participate at that level of knowing what they need.
It's like developmentally, he's just not there in that understanding.
Yeah, okay, great question. Yeah, and I think that's a good example, right? Because that's a complex situation, right? And I think a lot of times when we do work like this, we're kind of giving examples that are pretty like clear cut, but the reality is they're not clear cut usually, right? The ones we struggle with are kind of complex. I mean, so in that one, I think it would probably be pretty important to acknowledge that it is a different setup, right? That typically it is a space 100% for the client. It's 100% confidential. It's all about them. Um, but naturally, in this situation, that's just not going to be possible. So really what I would do there is focus on how can we as a team, and I guess I would kind of include their caregiver in that moment as part of the team, the three of us, me, the client, and the caregiver. And all three of us are working towards helping the client achieve their goals, right? So it's kind of like having another consultant or another therapist, not that they're playing the therapist role, but sort of that idea that they're a collaborative member of our treatment team, essentially. And we're still kind of focused on the client's needs and wants to the degree that we're able to identify that. Focus on the client, just having a better quality of life. Does that kind of answer the question for you, Kai?
Yeah, absolutely. Thank you so much.
Yeah, of course. Great question. Excuse me. So in terms of like taking a step back again and looking at these basic components of the clinical intake, and this is kind of based off of what we tend to see in Valent. I know that there can be some differences based on what clinic you're at, but my understanding is we all kind of use the same type of the type of form for our intake. So, first is our consent to treat. Second is discussing the presenting concern or the problem at hand. And then we're going to be talking about family history, support system, more information relative to the problem, and then our diagnostic impressions and our treatment plan. So we'll kind of follow that structure for our discussion today. So in terms of consent to treat, I think that this is a super, super important step in the process, right? And I really try to encourage people, don't make it be this thing you just have to check off the list, right? Like this is a moment to really start building trust with your client. This is a moment to engage with trauma-informed care, right? By focusing on consent from the get-go. So we always want to get both signed consent and verbal consent from our clients, right? So yes, legally, we are bound to get consent. That's really important. But like I said, consent to me in therapy is the building blocks of trust, right? Part of the magic of therapy that makes it work is it is a space where they know it is safe, right? They know exactly who has access to their information, when, and why, right? The other reason why I think it's really important to discuss this verbally with our clients is because we're all guilty of this, right? How many of us get a paperwork from our plumber, from our kid's school, whatever, that we have to sign consent and we just kind of skim it, sign it, and move on, right? So we really want to make sure that our clients understand specifically what they are agreeing to, right? I find it's helpful to give examples of what it can sound like. Everybody has to do their own style and their own thing. And obviously, consent can vary slightly state to state. But for an example, for myself, what I typically say as a practitioner in Pennsylvania, when I talk about informed consent, so I'll say, essentially everything you and I talk about is going to stay between us. There's only a few potential exceptions where I may ever have to break confidentiality. So that would be if there's like a really serious threat of harm to yourself or somebody else that might have to go beyond us. I'm a mandated reporter, so if I were to hear anything about child abuse, I do have to report that. Last case scenario would be like if my records were ever subpoenaed by a court of law. It's never happened, but it's always a possibility. And then I want to ask, do you have any questions about this? Typically people say, no, I understand, but I always like to remind them, consent is an ongoing process. I want my clients to feel comfortable asking me about consent at any point in the process, right? Like, well, hey, if this thing came up, like, can I talk about that in therapy? Can I not? Can that stay confidential? Really helping people understand that. I mean, I think especially with risk, specifically, we tend to see it more with suicidality. I think sometimes clients kind of think if they talk about having suicidal thoughts at all, that means that you're going to break confidentiality. And as we know, it's like way more nuanced than that. So I think this is a good space to just let them know, like, we can discuss these things. I want you to feel comfortable. I want you to understand. Additionally, once we get our informed consent, any other type of releases or consents that you need, this is a great time to get them for their primary care physicians, if they have a psychiatrist or something like that that you want to consult with. Depending on your clinic, they might fill this stuff out ahead of time, but these are considerations to think about if you want to make sure you have access to that stuff. A quick note here as well. We've got our consent to treat, and we're going to do so much information gathering with our clients. Something that I also like to keep at the forefront of my mind when I'm starting on my intake with somebody is this idea of hope installation. And this takes place throughout the entire process with our clients, right? We want them to feel that therapy can work for them, right? As we discussed, a lot of times our clients are pretty nervous to start therapy, understandably so. We want them to know, I'm here to help you. This can really work and this can really help. One thing I try to, again, keep in the forefront of my mind as I'm talking to them is maybe by the end of session, there might be something little that I can kind of give my client to do in between sessions. Even if it's just something for them to think about, right? Again, if we kind of put ourselves in our client's experience here, they've been with us for 50, 55 minutes. They've spilled their guts to us. They've been super vulnerable. And then we say, okay, thank you very much. And I will see you in a week. That can feel kind of daunting or like jarring for our clients, right? Like, okay, now what? So again, if you have time, if you have a second, I think it's great to think of just something little that they can do, right? Of like, if they're really anxious at work, like, okay, this week I want you to notice at work, are there moments that it's better and that it's worse? And notice what kind of is happening for you in the moments when that anxiety is variable. Something real tiny like that. If you have time, you could do like a little box breathing exercise and have them practice that, whatever it may be. Just something tiny to hold on to in between session, and again, help them feel like, okay, like we're kind of already moving forward here. Kind of back to some of the nuts and bolts, though. The big thing is discussing the problem at hand, right? What's bringing you into therapy, and what are you wanting to get out of therapy, right? So typically our clients are coming in for a reason, right? Whether they just think, okay, I've finally gotten to the point where I realize I can't do this on my own, or something happened, or they're just too tired trying to deal with everything, and then they're like, I need the support, right? So we want to kind of figure out what's going on there. It's going to be a mix of talking about what's going on in the here and now, as well as all of their background information of what led to this point. We're going to want to understand, were they just discharged from a hospital and they were referred to us? Are there any legal considerations? Are they on probation? Are they involved in like child youth services or DCF? What is the context that brings them here to us? And the more that we can understand that context, the better care that we can give to them. We know and they know that their issues didn't just pop out of nowhere, right? So this is really going to help situate us. Again, I find it's helpful to have examples. So for me, the way I kind of try to start my sessions is, like I said, I introduce myself, I give them informed consent, I let them know what to expect from the session today. And then I let them know, I've read all your paperwork. I so appreciate you filling that. I know it can be a little long. So I do have a general sense of what to bring you in, but I really want to kind of hear in your own words. So talk to me in your own words about what's bringing you into therapy today, right? And that can be a good place to start with our clients. A lot of times they say, oh gosh, I don't even know where to start, but kind of stream of consciousness can be an okay place to start, and then you can kind of guide them from there. So again, as I said, this is the client's problem, so we want them to be doing most of the talking. That being said, the clinical intake, just like session, but maybe even more so than session, the clinical intake it's a balancing act of managing the time well, because like we said, there is an awful lot we have to get through. So, If we need to redirect our clients, like we want to give them the space that we can, but if we need to redirect them, we can kind of do that in a supportive way. So again, an example for me, I might name, you've really given me a good sense of this problem, why, that's bringing you in. And we are going to get to talk about that so much more over time as we meet. But, I also wanted to make sure to have time today to ask you about this other situation, Z. Is it okay if we kind of transition over to that? And a lot of times people are really agreeable to that. They're like, oh yeah, like they kind of want some guidance. They want somebody to help walk them through the situation. A note here on time management. I'm a big proponent of clinicians finding their own style that works for them, right? So like, we don't need to do exactly what our supervisors do. We need to find our own style. But, just to give you a bit of a jumping off point, for me, if I can pretty much get through my introduction of myself in therapy and the general gist of the problem at hand in the first 20 to 30 minutes, that tends to be good timing for me. I can usually get done everything else I need to do after that. So that may not be what it looks like for you, but I do encourage you to start to take note of like what's good timing for me. Sometimes we have to be flexible. We have to go outside of that time limit. But it gives you a good benchmark to generally keep you on track. Additionally, when we're talking about the problem at hand, this is a great time to use our reflective listening skills, right? This makes sure that we're really understanding what the client is bringing in, but it also helps us build rapport. It helps them know that we understand them. It helps give them a sense of validation, right? Like this person gets it. So that this is a really good place to be focusing on that. And of course, we always want to give ourselves the leeway to ask questions so that we can better understand. I really encourage people to allow their clinical intuition to kind of guide them here, right? Like it doesn't have to be this very like bulleted list of like ask this, ask this, ask this. It can be kind of like a narrative interview situation, right? Of like, what do I want to know? What am I curious about? What's kind of like putting that like tingle in my ears of like, ooh, something that seems important. Like I think I need to know more about that. Like we said, I mean, this can take a while. So like we don't need to get all the information in our first intake session, but kind of trust yourself, trust your gut, go with where you need to and what feels important for you. Once we have a good sense of the problem at hand, we can kind of transition over to family history and support system, right? So we want to understand who is in their support, what's their biographical information, getting a sense of their parents. Are they living? Are they deceased? Were they together when they were growing up? What's their relationship like with them now? We may want to ask as well about like their siblings. Again, do they have a relationship with them now? What's that going to be like? How much detail we get into here is again going to be based on some clinical judgment, based on like what the problem at hand is. If I have a client coming in with a lot of childhood trauma, a lot of complex trauma, I'm probably going to be spending a little more time here, right? Bear in mind, you might have actually already gotten some of this information when you were kind of talking about the problem at hand. So, just keep your ears out throughout the entire thing for kind of what you're learning. But yeah, how deeply you go into things is going to vary. If you have a client that's coming in for an adjustment disorder issue related to losing their job, and they say, yeah, I have a great relationship with my family, supportive, great stuff, wonderful. That may not be where we need to spend a ton of time, at least in this initial session, figuring out. But again, it's always great to gather this information. As we know, family is kind of that building block of like attachment. So that's going to be important to know. Family history of mental health is always a helpful thing to know. And again, is their family and their support system a strength for them, or is it an area for growth? Once we kind of have a sense of the family situation, we also are going to want to refocus and get back to the client at hand, right? So we want to understand their education. What's their highest level of education? Did they have issues in school with being held back or developmental delays. What's their employment history been like? Have they had issues maintaining stable employment? Is a lot of their stress coming from their work? Stuff like that. I mean, the education and the employment can be really helpful. It helps us understand, you know, what kind of stressors they may be experiencing on the daily at work. We spend so much of our time at work. This is important to know. Is it a role where they may experience vicarious trauma? If they're a first responder or something like that, that's good to know. Again, their education level helps us understand, how they have done developmentally, what have been longstanding challenges, what have been newer challenges. Had they been given special support for ADHD growing up? Even if they feel they've grown out of that, a lot of times we're still going to see effects in adulthood and in employment. So really helpful information to get at there. We also are going to want to understand about their relationship information. Do they have a partner? Are they married, monogamous, open, ethically non-monogamous? Like, what does that all look like? Do they have kids, stepkids? What is the makeup of their kind of closest people in their lives? And of course, we also want to get information on substance abuse issues, any rehab, any mental health hospitalizations they've had in the past, legal history, all of that important stuff, just to make sure we have the best picture possible of what's going on for them. We also want to get some further information about whatever the problem at hand is, right? So we've explored the key issues. We generally have a sense of what's going on. If we have the time, we can really start drilling down on some of the particulars, right? So what has substance use been like for them? What have the consequences of use been like? Substance use is always one that the devil's kind of in the details, right? So something I like to ask my clients, like if I say, what's typical for you? And they say, oh, 3 glasses of wine, I don't know, 4 times a week, both weekend days, 2 weekdays. Say, okay, that's good to know. And I say, okay, so once you've poured your 3 glasses, how much is left in the bottle typically? And sometimes they say, well, that is the bottle. Like 3 glasses is the bottle, right? And so that gives us some more information, right? Or if they say, oh, I drink, 4 beers. And it's like, okay, what's a beer for you? 12-ounce, pounder, what's that? And they say, oh no, it's a pounder. It's 24 ounces or whatever, that gives us a lot more detailed information. So this can be a good place to spend some time. We also want to understand their history of risk, both risk for themselves as well as like any homicidal information that they have had. Explaining or sorry, going into risk management. I mean, this is a big topic. We're actually going to do another TCN EDU that I'm going to be presenting on suicide assessment. I think it's going to be in April, I believe. So we could spend so much time on risk assessment itself, and I really encourage you, if you can, to attend that TCN EDU event as well. But this is an important one, right? I always like to make sure I've saved time to talk about SI with my clients. Like, I don't want it to slip my mind and be the thing I'm talking about in the last 10 minutes, because, a lot of times our clients are like, no, I'm not experiencing that, or, they've had it, but a long time in the past. But sometimes you have clients that are like, no, I'm not experiencing that. I did get discharged 2 weeks ago for an attempt, but I'm not experiencing that right now, right? So it's like, okay, we got to do some more digging here and figure out what's going on. So we really want to get a really nice history of that for ourselves. Again, we also might want to see if we can get information from their PCP or their medical history, whether it's from them in particular, or from their records from their provider. Are they on any other medications? Do they have other medical issues that could be kind of addressing or causing more problems for them, like chronic pain or thyroid issues? Again, do they have a family history of mental health and substance abuse, developmental issues, school issues, social history, all that stuff. A quick note, I will say, kind of going back to our discussion on like assessing suicidality. And we're going to talk a little bit about the assessments that we have available to us in Valent, but one that can be useful here is the Columbia Suicide Severity Rating Scale. If someone is having active SI, that can really give you a nice baseline. You know, the bottom line is we always want to make sure we're asking and assessing. And if they have it, how often are they having it? How long does it last? How intense is it? How manageable is it for the client? You know, what are the protective factors? All that stuff. Typically, how it sounds for me as an example, you know, if a client is talking about, you know, having had SI, then I'll just get information then. But, you know, even if it doesn't really seem like they might be someone with that history, in the intake, I'll say, you know, I always like to ask people this when I first meet them, you know, and as we continue to work together with everything that's been going on, or with all the stress you've had, what, if any, thoughts have come up for you about wanting to hurt yourself or wanting to kill yourself? And then I'll also ask any thoughts about wanting to hurt other people or kill other people. So again, just gives you a little bit of a sense of what it could sound like, but you know, we could spend so much more time on this, and we will. Once we've gotten all this information, we really want to be thinking about our diagnostic impressions, right? Of course, we need a diagnosis for insurance purposes, but really the importance for me with the diagnostic impressions is it helps us with our treatment planning goals, right? So, you know, thinking about, is there evidence of a major mental illness in their past? You know, so if they are reporting they've previously been diagnosed with major depressive disorder or GAD or bipolar disorder, whatever it may be, this is a good starting point. You know, always back it up with your own observations, your own information in the here and now, you know, but this is a good place to start. When we first meet people, we may not be able to give them a full, like, concrete diagnosis, right? It may take a couple weeks to suss that out. So we may kind of be starting with like a depression or anxiety. But again, this is a very small snapshot. So we don't So we don't want to be biased towards our initial diagnosis. You know, we want to really allow our mind to be open to changing possibilities, right? So even if you start with like an adjustment disorder with anxiety or depression, you know, we're kind of keeping that diagnostic ear open in the first couple of weeks and throughout the entire time that we work with our clients. You know, again, certain things diagnostically just take more time to suss out. Something like a personality disorder, you know, typically we're not going to be diagnosing that after meeting with them one time. You know, something like PTSD can look like a lot of different things, right? It can mimic ADHD, depression, anxiety. You know, so it's going to take time to suss all of that out. You know, I also had mentioned that we have these great assessment tools in Valent. These are really helpful. In our intakes, I believe that it typically auto-populates the PHQ-9, which is a scale for depression, and the GAD-7, which is for anxiety. So we are going to, you know, assess those in our initial intake with our clients. And I want to be kind of a proponent here for using these tools, not just in the intake, but in our subsequent sessions as well, right? This helps us understand, is our client making progress? Are they experiencing a decline? You know, we know from the research that we as clinicians, we're humans and we're not as good at detecting decline as we would like to be. So this helps us. You know, sometimes also clients, they grow to like us, to value our goodwill towards them. So sometimes they can find it hard to be honest at a certain point if they're struggling. So this is kind of an objective measure that might cue us in, you know, and we can kind of look at it. It's also really nice to be able to show our clients like a little bar graph or a little line graph of their progress and their success. So it's really helpful for that. I mentioned there's the Columbia Severity Suicide Rating Scale for SI. There's also the NIDA quick screen for substance use. There's tons of assessment tools that you can elect to add in to your intakes or your subsequent sessions. So if you haven't, I would definitely encourage you to just take a little look and see what all is available for you. But we definitely are going to want to do the PHQ-9 and the GAD-7 in our initial intake. A quick note here on assessments for clinical intakes with children. There are 2 additional screeners that will be in the child intakes. The child symptom screener and the HDCLC for childhood depression. questions for these screeners, you're going to be talking with the parents, but you also may be including the children, depending on the age range and the developmental appropriateness of this. You might do it in the first or second session, but it's kind of time consuming. So it is something to kind of be mindful of where you're going to put that into the process. Okay. And now we're going to kind of talk about our treatment planning process, right? So I know we're coming close to our 15-minute mark here, but the treatment plan is kind of is the end of like our initial intake process. Now, you may not get to this in the first session. A lot of times I don't get to it, and sometimes that's the client's homework, is starting to think about concrete goals that they want to make sure they're working on. It can be helpful to start with a combination of your client's reported problem and your diagnostic impression of them. We're going to keep working on the treatment plan collaboratively, using the client's goals and objectives and figuring out what interventions would be really helpful here. Again, as I mentioned, therapy is a team sport, and I explain this to my clients. Yes, I have expertise on psychological matters, and you as the client have expertise on yourself. So we are both kind of coming together with our expert knowledge and working together. And that's going to be, we work together on the treatment plan, and we work together all the way throughout the entire process, right? Sometimes clients struggle with knowing what they want. They're like, I don't know, I just want to feel better. So sometimes I'll ask my clients, okay, well, think about it this way. If it was sometime in the future and today was like the last day of therapy, we're like high-fiving, we're like, we're done, we did it, like we accomplished everything. What would be different in your life? What would look different? And this a lot of times can give people a sense of what their goals might be. And finally, just some additional considerations. The initial intake, as I said, it's a lot of information that we're getting, but I really would encourage you not to lose sight of the fact that most importantly, we're starting to build a relationship here. If I don't get a little bit of information in the intake, that's okay. I can get it next time or the time after that. We really want to make sure we're building rapport and making them feel comfortable with the idea of therapy and with us, right? As I mentioned before, too, we also want to be explaining the difference between intake and regular sessions. We might even want to explain a little bit about our style as a therapist and how we approach therapy. I always like to ask my clients at the end of the session, I kind of explain a little bit about my approach. And then I say, so how do you feel working with me? Do you feel okay giving it a try for a little bit? Or do you feel like you need something else or a different approach with somebody? And a lot of times they'll say, no, I feel comfortable with you, or, we can give it a try. So again, it's also kind of this other like micro moment of consent, of trust building. Like, do you want to work with me? Are you okay? You're in the driver's seat. So I want to make sure you're comfortable. If I'm not your cup of tea, that's okay. I'll help you find somebody else that is. But typically, if you've done a nice job with rapport building, then they're comfortable giving it a shot and giving it a try with you. So I know that's kind of a little bit of a whirlwind, but I think we have a little less than 15 minutes. So I think we did pretty okay on time. What sort of questions do people have? And I'm going to go ahead and stop sharing so I can read the chat as well.
We had one from earlier in the chat, which was from Alfonso. That was, I have a question. When gathering information during initial couple of sessions, is it best to go through all the questionnaires or bring them up as your clinical judgment implies? I ask because exploring the problem doesn't necessarily require the need to ask multiple questionnaires except the PHQ-9 and the GAD-7.
Mm-hmm. Yeah, great question. Yeah, that's kind of how I do it as well, Alfonso, like the PHQ-9 and the GED, like I do like read those questions. But I try to make it as narrative as possible. So like I said, as you're talking about the presenting problem, a lot of times you get a lot of background information. I agree. I don't think you have to go through like this bulleted list of ask this, then that. And as you get more comfortable, not only with the intakes in general, but like with specifically how the note is set up in Valent, you kind of have a little bit of like a mental guide or a mental script almost. So yeah, I totally agree. For me, the more narrative I can make it, the more of a conversation I can make it, the better.
Hi, I also had a question.
Yeah.
I'm wondering when it comes to diagnoses, and I know that there's another like diagnoses training, but in intake, if a client shares with me that they have been previously diagnosed with something, how do you recommend going about that?
Yeah, great question. And this is a tricky one, right? Because I think depending on how much contact with the mental health field our clients have had, they could carry quite a few diagnoses, right? I think especially like working in an inpatient setting, like I would see patients come through like with tons of diagnoses, and it's like they probably don't really have all of those, but it's like people have been just like diagnosing them with what they think is going on as they've been seeing them, and they kind of just stay with them. So for me, I'm like, okay, that's great information. I might ask them, how do they feel about that diagnosis? Do they feel it fits them? Um, I will ask them like, if they're saying, okay, I've been diagnosed with bipolar, I'm like, okay, talk to me about that. I'm going to be assessing for mania. I'm going to be assessing for these things. Um, so again, it's a good place to be like, okay, like this is good information. They might have this, but to me, I don't really take that as a foregone conclusion. Like I take that as an opportunity to explore, but also making sure I'm really using my own clinical judgment and not being biased by hearing that they've had it before and then kind of like having that confirmation bias and hearing everything confirming that, if that kind of makes sense.
Yeah, totally. Thank you so much.
Yeah, for sure. I'm seeing a question in the chat about, oh,
Sorry.
oh no, you're good. I just was seeing a question in the chat. Oh yeah, perfect. It looks like Aaron answered that, so that's wonderful. Kai, you were gonna ask a question?
Yeah, actually, about the two screeners that were just put into the
Yeah.
chat, are those only required for minors who aren't age appropriate for the PHQ and the GAD-7, or are they required for everybody under 18?
That is a good question, and I'll be transparent here. I don't do really a lot of child work, so I would refer to your clinic director specifically, like for your clinic, like what the expectation is there. My understanding is yes, that it's going to be for under 18, but it might be under 14. I'm not completely certain, so I do apologize. I don't have that information for you, but actually, too, like I'll let me get that information for you and I can kind of send that your way if that's okay as well.
Awesome, that would be great. Thank you so much. I
Yeah.
really appreciate it.
Yeah, great question.
Thank you.
I have a quick question.
Yeah.
So how would you go about bridging the gap between how the questions are structured in each assessment and the cultural differences? Because if you're working with an honor and shame culture, for example, the questions might be too direct, or they might even cause like a lot of embarrassment, and it might even be a barrier. So how would you go about that?
Yeah, that is such a fantastic question. I really appreciate bringing in like the cultural competency angle into this discussion. And I think that the way that I try to approach that is by, when I get this background information, right, of like their family history or their cultural history, like, okay, thinking to myself, of course, I don't want to automatically assume that somebody is going to carry or not carry certain values of different cultures, right? Like we can think about different acculturation models. Sue and Sue is a fantastic resource here. Um, so being mindful that this may play a role, but I also don't want to put that on somebody, right? And to me, I'm going to be really looking at how they're responding to me. Do I feel that they're really responding to me strongly as an authority figure? Like they kind of want me to tell them what to do. And I'm like, okay, is there a cultural underpinning here? Right. And in that case, I'm willing to be a little bit more directive than I might typically be to make sure I'm meeting that client where they're at in the moment. Right. And for me, you bring up a good point about the directness. As I said before, I'm going to prioritize the rapport building and the relationship building over information. Of course, when it comes to things like safety, yes, we have to make sure we have a really good understanding of that from the get-go. Um, but otherwise, I'm willing to take it a lot slower. So if I can't really get all the information that I want right away, that's okay. Like we will get there. That will all come out. So yeah, to your point, I'm willing to kind of like take it much slower, or, you know, if I'm sensing that they're not really going to be willing to go here with me on a certain topic, that's okay. Like we'll get to that eventually. But yeah, I think to me, it's really about keeping those cultural considerations to the forefront without putting them on the client necessarily, but recognizing how are they relating to me and relating to the mental health field in this moment. Does that kind of give you a sense?
Yeah, it does. And I think maybe you're gonna talk a little bit more about that in the suicide risk assessment training. But like, for example, the CSSR has to be asked in the way it's written.
Yeah.
So that's kind of one of the things that, could be a challenge. So yeah, I think when the assessment is kind of like has to be asked in that exact way,
Oh, I see what you're
that
saying.
becomes a little bit more challenging, I guess.
Mhm.
And I don't know, I might be reading way into that. So I
Yeah.
just want to know what's your take on that.
No, I hear what you're saying. I mean, I'd have to do a little bit of digging on like the psychometric norms of the Columbia Suicide Rating Scale. Typically, they are normed on like the general population, which is going to include people of different cultures. So, you know, to a degree, it's going to be baked in there. Now, to me, I think it depends on what your goal is. Like if my goal is to administer this measure with complete fidelity, then yeah, okay, you have to kind of read it exactly as it's stated. In the clinical setting, that's not really my goal. My goal is to get the information. So I'm willing to kind of change and alter the way that the questions are asking in order to make sure that I'm kind of getting like the spirit of the question across to the client in a way that they can understand and respond to. Now, if I do that, I have to then be mindful that like the number that gets spit out at the end of that assessment is not going to be 100% accurate because I didn't administer it with true fidelity. But that's okay to me. That's still information. Does that kind of get at it more directly?
Yeah. Thank you so much for saying that, because it takes the weight off a little bit, because
Yeah.
like again, the biggest challenge during intake is to build rapport and trust, and in the meantime, not kind of like scare the client, because
Yeah.
it could be the first time, it could be another time after a bad experience. So
Absolutely. And I think too, a lot of times, like if the client is endorsing more current SI, I will spend more time talking about the informed consent piece, right? Of like what it means to talk about risk in therapy. Like my approach, and everybody's different. We'll talk about this in the suicide assessment, is to be collaborative. Like for me, my clients never have to go to the hospital unless they want to. What I mean by that is as long as clients can work with me and create a plan with me where we both, me and them, feel comfortable that they can keep themselves safe, we don't have to go beyond this. That's not necessary. We will if we have to, if they can't, work with me to make sure that they're staying safe, but I give them as much control as I can there. So I may dig into that a little bit more as well if it comes up in the intake, just to set people's mind at ease. Other kind of questions. I'm mindful of time, and I want to say real quick thank you to Frederick who put some information in there about the child screeners versus the GAD and the PHQ-9. So we really appreciate that. I recognize that people have to get to different appointments, different sessions. So if you have to log off, totally fine. But I'm happy to stay on for a few more minutes as well if there's any questions that people have. Also, I'm trying to see, I'm happy to share my email if people have any questions that they'd like to reach out to me about. I'm more than happy to do that. But otherwise,
one more question in the chat from,
yeah.
I think it's Haley. If a client has been through 3 to 4 intakes at the organization in the past year, is an intake questionnaire needed or required when you're able to review previous notes?
The client's been through 3 to 4. So again, I would defer to your clinic director. At my clinic, if they're starting with me new, I do have to do a new intake, but I do a much more abbreviated version. Like a lot of that information, like the background information, that's not really going to be changing. I'm not really asking about that again. I'm more asking about updated stuff like current substance use, current problem. So yes, you do, at least in my clinic, you do have to do it, but it's a lot more streamlining quicker, and I kind of get down to the meat and bones of it, or meat and potatoes of it, a lot quicker.